My name is Santiago Encinas from Peru, and my co-chair will be Professor Antonio Fea from Italy. And we are so glad to present this session because hypotony is one of the worst situations that glaucoma specialists going to have to manage. Let me introduce you our speakers for this session. First, Professor Bisani Tantisevi from Thailand will talk about conservative management of hypotony. Then, Professor Shlomo Melamed from Israel going to talk about psychodialysis cleft. Then, Professor Shenton Xu from New Zealand going to talk about post-trabeculectomy hypotony management. And finally, Professor Sonja Bennett from New Zealand going to talk about hypotony post-tube management. At the end, we're going to have some minutes to answer your questions. Thank you very much.
Hi everyone, I'm Visni from Chulalongkorn University, Bangkok, Thailand. Well, I have to go on with the lowdown on hypotony conservative management. This is my financial disclosure. As the first speaker, I would like to put some scopes on the hypotony. I would go on with the overview, the treatment concepts, and the management, particularly on the conservative measure which I'm focusing on. Hypotony has variation in numerical cutoff. WGA has shown that below 5 mm mercury is non-physiological, but should be along with possible clinical complications. So we need to look for the hypotony-related complications too. Well, it can be classified into two, statistical or numerical, which means that low number but nothing wrong with the eye. Clinically significant, which means that the low number, its IP is low enough to result in visual loss. The effect of hypotony, what is it? It can cause the eyeball to shrink and then got on with a vision drop off. And this vision drop off can be permanent. That's why it's clinically significant. The first thing we have to look for is the maculopathy. It can be mild or severe, just like this on the right hand side, this edema, macular striae, and vascular tortuosity. With this investigation, you can see that what hypotony can go on with, the ocular integrity. And on the FA, on the right side, it can show you that some kind of a leakage over the edema. Other things that, the choroidal effusion, because the hydrostatic oncotic pressure gradients are disturbed, and there is some accumulation of translate inside the suprachoroidal space. Moreover, it can accelerate the cataract maturations, and it can do something to the corneal endothelium, make it dysfunction and make the corneal edema. And perhaps the first thing that you can see is the descemet membrane folds. So that's why we have to, if there is something like this happen, the hypotonic keratopathy can happen. Causes of hypotony are many. AOL has listed many things, but most of the time it occurs after the operation, particularly our filtration surgeries. And the risk factors who will develop it just listed over here: male, myopia, young age, and the use of anti-fibrotic agents. So the management concept is quite easy. So simple as it is, just if the IP is too low, just raise it up. Because when the IP is low, it can disturb the ocular integrity. When you raise it up like this, from 5 to 15, and when it goes up, everything just can turn back to normal. But we have to do it in a timely manner. Well, why we have to do that? Because the final goals of this treatment is to re-establish the visual function. The post-glaucoma filtering hypotony can be classified into early or late. It depends on what time it happened after surgery. For the early, usually it comes from the overfiltration or the blood bleed. But that said, might be a little bit different because it might be associated with avascular cystic bleps, and it can cause the serious things more than the early. For the post-filtering hypotony management, you can do it as conservative or invasive, but in a timely manner I just mentioned. Perhaps you need to look for, if it's just only numerical, you can wait and see. But if it is clinical significant, it can lead to visual deterioration, and you must do something. For the conservative measures, involve a lot of things, just like the agents, just like the accessory tools like a contact lens or the Simmons shells. So Not just only that, usually we start with the precautions against the aerobic and physical exertion, and then the agents that involve a lot, like a cycloplegia, the steroids to reduce it or raise it. It depends on the course. But as you can see, the common conservative approach might involve many things: contact lens, immunosuppressants, topical lubrication, and usually the cycloplegic agents. Well, for the early hypotony management, from my belief, there are recommendations just like this. However, for me myself, I just do it just like with the reduces the steroid, cycloptic eye drop put in, and using some antibiotic like aminoglycoside because it can cause some, mild irritant and stimulating the cells and seal the leak. Echosupressant can be used at sometimes. This is for sealing the leak and maintain the optimal filtration space. For me, oversized CL, I didn't use it. The fibrin glue, I think it would not work because the glue would work effectively with the dry area, but the leak edge is always wet. I never use the agar laser. And for the early hypotony management with the overfiltration, there are recommendations too. And you can see the steroid and the cycloplegic eye drops is the most thing that we are, employing for, to get the increased filtration resistance. When the filtration resistance increase, it can increase the LP as well. For the hypotony management is something different, and as I mentioned again, well, it's associated with a vascular cystic bed. So consumptive itself might not be working effectively because if you leave the leakage unrepaired, it may leave the eye vulnerable to infection. But sometimes the rules can be violated. You can see here with a female 81 years of age. One of my patients at the year 2008, she has advanced VACG, blind in one eye, the right eye just counting finger. She got trapped in MMC for many years, control her PQ was well. However, when she got on the schedule follow-up with no complaint at all, the VA is still the same, but we observed something different. She got just only low diopy at 4, significant CD, the shelling of the anterior chamber depth. However, the macula still spared, this fully cupped, no edema. The bleb at our examination time was no sign of leakage at all, but we believe that there might be something have happened before that. So I thought to myself at the time, this is one eye patient, and what should I do? Should I aggressively intervene? But because of many reasons, I decided not to. I started with the non-invasive or the conservative first because I believe that at that time the surgical repair may bring trouble because she had no complaint and she had a very extensive area of vascular bleb. The bleb you can see here is not her true bleb because I could not find her true image. This is from the internet, which is very similar to her blebs. She got a very small eyeball, no palpable fissure, so I start with that. And anyway, fortunately, so fortunate for me that the 6 months after, the appellation just got back to just a little bit higher to 6, but we are still the same. But everything seems to get improvement. SCD regained, CD gradually decreased. At 2015, about 3 years after the first approach, everything just seems to be stabilized. The bleb same appearance, SCD deep, and the CD gone and flat retina. So the agents can be, tail off until just only once a week. And for me, I think the constitutive measures. This is a take-home message for this measure. I think it can do well with the for the mild or moderate form of ocular change, but need the timely intervened. It can restore the IOP, the structure, and the VA, but might take time. Closely monitoring is quite important because you need to look for improvement during that time. And if the sign or symptom cannot be improved, please do not hesitate to consider other interventions. Otherwise, you cannot save the patient's sight. And that's for now from me. Thank you for your kind attention from Chulalongkorn University. Welcome.
Good day to all of you. It's a real pleasure to be back at the WGC and give a talk. Hopefully, very, very shortly, we should be able to meet in person. This is much better. The topic, my topic today is the cyclodialysis cleft. I have absolutely no conflict of interest to declare regarding this topic. And before we start, I think we should really define what we are talking about. The definition of a cyclodialysis cleft is a separation of the ciliary body from the scleral spur, thus creating a direct communication between the anterior chamber and the superciliary space or the suprachoroidal space. The cyclodialysis can be either post-traumatic, either iatrogenic, or therapeutic, and we shall discuss them all. First, let's talk about the traumatic or the post-traumatic cyclodialysis. It usually follows blunt trauma of the eye, and the blunt trauma should be aimed at the cornea and the anterior chamber, and by that creating vectors of blast that go laterally into the angle. And this blast of energy going laterally into the angle in 360 degrees creates that kind of damage, which is called cyclodialysis cleft. It is usually associated with iris sphincter tear and hyphema, also the result of the trauma. It is very rare indeed. In a series of 145 eyes only of blunt trauma, only 6.9% had hypotony, and only 2% of them had proven a cyclodialysis cleft. So it is very rare and hard to diagnose. Hypotony usually follows cyclodialysis cleft, and without hypotony, you cannot make the diagnosis. The reason for the hypotony is as follows. The pressure in the superciliary space is usually between -3 and -5 millimeters of mercury. So communicating the anterior chamber with the superciliary space usually results in a suction effect of aqueous and very low IOP. Usually hypotony, maculopathy, and choroidal folds also are part of the hypotony, because it's usually very, very extreme, very severe hypotony, and they reduce vision. By the way, corneal edema may also follow. And spontaneous closure of the cleft is usually associated with dramatic increase of intraocular pressure. But hypotony after blunt trauma is not always associated with cyclodialysis cleft, because the cleft itself is indeed very rare. There are other causes for this hypotony: trabecular meshwork tear, reduced aqueous formation due to the ciliary body separation and malfunction, retinal detachment, which may be associated with the trauma, and in chronic cases, cyclitic membrane formation as well. The diagnosis of the cyclodialysis cleft requires hypotony, but it also depends on visualizing the cleft by either gonioscopy or by imaging, be it UBM or anterior segment OCT. First, gonioscopy. We really need to visualize the displaced iris root and the ciliary body posteriorly. The cleft can be white. You can see a sclera shining through the cleft, as you can see on the left-hand side with my white arrow here, or gray-black with pigmented tissue that is remnant from the trauma, as you can see in the other two slides below. Often it's very, very hard to visualize due to hypotony, corneal edema, hyphema in the anterior chamber, and peripheral anterior synechia, sometimes covering the cleft. With UBM, it's very nice to visualize the cleft, which is associated here, communicating between the anterior chamber and the superciliary space, which is very large, containing a lot of aqueous coming in. Also, the anterior segment OCT, with this technology, you can also visualize very large or relatively large superciliary space and damaged area here between the anterior chamber and the superciliary space, indicating the place of the cleft. We also have what we call iatrogenic or inadvertent cyclodialysis cleft. And they usually occur after surgery, sometimes complicated surgery. You can see it after trabeculectomy. You can see it after cataract surgery that has been surgery that was complicated by all kinds of events during surgery, and after iridodialysis as well. What about the treatment options of cyclodialysis cleft when we diagnose it? We have the familiar triad of medical treatment first. If it fails, we move on to laser treatment. And if this fails, we resort to surgical treatment. First, the medical treatment. It is usually suitable for clefts smaller than 4 clock hours. Larger clefts will never respond to a medical treatment. We usually use a 6-week trial, then we laser or move on to surgery if the medical treatment is not successful. Some small clefts, as we said before, may close spontaneously, sometimes associated with very, very high intraocular pressure, which is a main problem. We use cycloplegic drops in order to relax the ciliary body and improve the chances for closure of the cyclodialysis cleft. And we also use steroids in order to elevate the intraocular pressure because of the extreme hypotony associated with it. If after 6 weeks the treatment with cycloplegia and steroids fails, we move on to laser treatment, and this should be applied to both the ciliary body and the scleral spur. The laser beam induces scarring to close the cyclodialysis cleft by causing some kind of inflammatory reaction, which will bring fibrosis later on and reattach the ciliary body back to the sclera. It is wise to treat the deeper, non-pigmented aspects of the cleft first in order to avoid pigment dispersion blocking the laser beam. It is a very difficult treatment. Multiple treatments may be required, and sometimes retrobulbar anesthesia is desirable because if you use higher energies in order to induce a lot of inflammation, this may be painful in some patients. If laser treatment fails, we resort to surgical treatment, and the main idea of the surgical treatment is to expose the supraciliary space, to identify the detached ciliary body and reattach the ciliary body with sutures to the sclera. It can be done like here in photograph depicted C, as you can see. First of all, you expose the supraciliary space, you isolate and you identify first the ciliary body, and then you put sutures that are very deep and will include the ciliary body and reattach it to the sclera. It is amazing how the ciliary body is not bleeding, and this is really nice to see, because apparently the ciliary body has a reaction of spasm when you try to put a needle through it, and this is very helpful to us. In very large cyclodialysis clefts, and this has been described in BJO by the Kit Barton group, they recommended the formation of a very large scleral flap, very deep scleral flap, full thickness in fact, and you can identify the problem with a ciliary body which is detached, and you put sutures directly in the ciliary body, you drag it into the sclera, and in that way you can repair the cyclodialysis cleft. It's a very, very difficult, long surgery, and but the success rate is very surprising. What about therapeutic cyclodialysis? We have surgical cyclodialysis, we have the gold shunt into the supraciliary space, and we also have the CyPass. There's an internal tubing of the ciliary, of the supraciliary space. Cyclodialysis surgery has been abandoned because it is uncontrolled. It is a semi-blind, or I would say even fully blind surgery. And even if you are successful, the pressure goes down to 0, and then you have IOP spikes with cleft closure up to 60, 70 millimeters of mercury. It's really a major complication. So I don't think there are too many people in the glaucoma field that are still doing that kind of surgery. But we thought about using a more controlled kind of a cyclodialysis cleft. That's why and I was very actively involved with the gold microshunt surgery, and also the CyPass, which was a tube into the anterior chamber. I start with the gold shunt below here, the GMS, and you can see it on the left-hand side, is a miniature gold-made shunt, especially designed into the, to be implanted into the superciliary space. We had at the time 70% success rate in refractory glaucoma cases, but due to all kinds of reasons, mainly sometimes fibrosis in the superciliary space and some complications associated with corneal involvement, the GMS has also been abandoned practically. The CyPass, which was a tube, as you can see on the right-hand side, it was inserted by ab interno approach into the superciliary space, was at first also, like the GMS, very successful in IOP control, but it was recalled by Alcon due to corneal endothelial cell loss. It was progressive. And this recall, by the way, affected very, very dramatically the attitude of the FDA towards the GMS as well. So right now we're in a position where we do not have implants into the superciliary space, so that even the controlled cyclodialysis cleft has been abandoned for now. So thank you very much, and I will be happy to take any question from you regarding this topic. Thanks a lot.
I'll be presenting on post-trab hypotony today. I've got no financial disclosures to report. Now, as glaucoma specialists, we're all familiar with the challenge of our treatments causing only negative effects from our patient's perspective, and trabeculectomy surgery is really no different. At the best of times, I'm warning patients that they may get ocular surface symptoms despite even perfect bleb morphology, or that their vision is going to fluctuate for 3 months post-operatively. Postoperative hypotony is a significant complication that can make things particularly stressful for both patients and surgeon. Their vision can be poor and their acutely hypotenuse eye can be uncomfortable. It's important to make the distinction between numerical hypotony, or what I call ocular hypotension, and clinically significant hypotony, which implies sequelae from the hypotension. Now, these sequelae include AC shallowing, best seen with asymmetry between their AC depths, Bowman's folds with fluorescein application, and chorioretinal folds best seen on OCT with a vertical raster pattern. The importance of early recognition is that hypotony can be a lot more difficult to treat if left unchecked due to a vicious cycle of low pressure causing inflammation, reducing ciliary body function, leading to ciliochoroidal detachment, which further reduces aqueous production. For this reason, the best way to manage hypotony is to prevent it from occurring in the first place. Young myopes are at the highest risk due to their thin and elastic sclera having the least resistance to flow. Other factors include conditions that may have reduced ciliary body function, such as uveitis or neovascular glaucoma. I think that scleral flap creation is crucial in both early and late hypotony. To encourage long-term posterior flow, I prefer a rectangular flap. If anything, I'll err on making a curve so that the posterior part of that flap is as close to the sclerostomy as compared to the anterior arms, and this will encourage posterior flow. I believe that anterior flow is the main culprit in those cystic avascular blebs that have a propensity to leak and cause late hypotony. A major error that I see is creation of a flap with non-uniform thickness, so thinner at the sides than centrally. These lead to more anterior leak and less posterior flow, and they're also difficult to close on the table. And the reason for this is people are using a side-to-side motion rather than a curved motion with this crescent knife following that curvature of the globe. If you come to flap suture closure, then you really need watertight closure, and usually I use 2 releasables, but in these cases I'll add a couple more along that posterior part of the flap to be sure, and I'll check for leak. with fluorescein as well in between each suture pass. In terms of conjunctival closure, to prevent bleb leak, I favour a purse string style closure at each end of the wound. I feel that this provides excellent tension and less leak. Despite these measures, if you do find yourself with a patient who has early hypotony, you must assess their bleb height, and if this is low, then side-arm testing can confirm a wound leak, though you may need to elicit pressure across that bleb through the eyelid. If this is the case, then bandaged contact lens application can stop this leak. If it's really brisk, then resuturing may well be needed. Stopping the steroid can also help if you're using bandaged contact lens. If it's side-arm negative, then consider a cyclodialysis cleft or ciliary body shutdown, and for the latter, try some oral steroids. If the bleb is high, then you're looking at overfiltration, and especially if this has happened after removal of a releasable suture or suture lysis. And in this setting, I'd start with medical treatment, so atropine to deepen the anterior chamber, prevent PAS formation, reducing the steroid or stopping the steroid to invoke inflammation and scarring. If the hypotony sequelae are quite prominent, such as larger choroidal detachments, then I would consider AC reformation with a viscoelastic. I prefer to do this at the slit lamp and measure up 0.1 mils of Helon or Provisc so that I know exactly how much has gone in. If you want, you can consider a denser viscoelastic, either Helon GV or Helon 5, but be aware that these denser ones can really spike the pressure, so be careful of the volume that you use. If things are not successful, then you can consider an autologous blood patch or transconjunctival suturing of the scleral flap or compression sutures, and a technique that's been recently described are these two 9-0 nylon figure of 8 sutures, one across the ostium and a second one across the posterior edge of the flap. This sort of makes a lot of sense to me, but personally I do prefer to revise these traps under direct visualization, so reopening the conjunctiva, using an AC maintainer, which I think is really helpful to look for flow on the table. This really gives me the best chance to sort out the hypotony, and I try and do this within 6 weeks. Here's an example of an over-filtering bleb with an incompetent flap edge, and this requires placement of the releasable and also a fixed anterior suture for good measure, and this has sorted out the increased flow. Remember, 2% fluorescein is really helpful. In this case, there's a brisk anterior leak. It's also successfully closed by resuturing. But when the bleb leak is this anterior, or if you're struggling to control the leak despite sutures like here, then you should consider scleral patch grafts, and you can use a pericardial patch graft as well. If you're worried about blocking off too much flow, you can use releasables on your patch graft as well. Now, the approach to late hypotony is slightly different. The bleb morphology remains important. If the bleb is cystic and avascular, then side-arm testing is likely to show a bleb leak, which will require trab revision and bleb excision. If the bleb is flat, intracameral gas testing is beneficial. I use isovolumetric SF6, and what you're looking for is subconjunctival emphysema. If you don't see this, then again consider cyclodialysis cleft or ciliary body shutdown. If it's present, such as here, then consider overfiltration. In this context, if there is a visually significant lens opacity, then dealing with this with cataract surgery can reduce the trab function by promoting inflammation, and is a good option. It's less invasive than if there isn't, which is going to require a trabeculectomy revision. In this case, where there's a leaking cystic anterior bleb, note that we've performed a wide conjunctival incision with substantial subconjunctival dissection to minimize the tension during closure following the bleb excision. In this sort of case, use of a scleral patch graft is essential to prevent anterior flow and to direct that posteriorly so that you can avoid recurrence of that cystic bleb. that would probably happen if you just did a simple conjunctival advancement. In summary, I hope that I've provided you with some clinical tips on post-trabectomy hypotony management. Remember, prevention remains your best strategy, so take your time in the initial procedure to get it right. I'd also like to acknowledge Keith Barton, one of my fellowship supervisors, for some of the video content used in today's presentation. Thank you very much for your attention.
Good morning, it's a pleasure to be with you here in the first World Glaucoma E-Congress. I'm going to be speaking from New Zealand this morning on low intraocular pressure post-glaucoma drainage tube implantation. To my mind, post-operative tube hypotony is best avoided rather than treated, and so pre-operative planning is the most important stage in avoiding post-operative tube hypotony. I recommend that you plan your surgery carefully so that the prevention of hypotony saves much angst and sleepless nights in the post-operative period. Look for risk factors for hypotony to identify high-risk patients before you take them to the operating theatre. Younger age, large eye, a person who's been vitrectomized or is aphakic, a patient who has scleromalacia or previous scleritis, and of course a patient with uveitis. Often patients who've had uveitis for a long period of time have reduced aqueous input, and so the balance between the aqueous entering and exiting the eye is very fragile. Intraoperative considerations. Make sure that you minimize the number of incisions in the eye for obvious reasons. You don't want the eye leaking. Use a suitable intraluminal suture if you're using a non-valved tube to provide resistance to flow, and it also provides strength within the tube so that the ligation sutures can be more easily effective when applied from outside the tube. Make a small gauge passage for tube entry into the eye. I normally use a 25 gauge needle with my current tube that I use. And also make a reasonably long intrascleral passage to minimize aqueous leakage. I recommend using more of a tangential intrascleral passage rather than directly radial. Other intraoperative considerations are to check the flow of the aqueous through the tube if it's non-valved. There are two different ways to perform this. One is an active flow check, where you gently insert a Rycroft cannula into the tube's distal end and put pressure on your syringe with BSS. If there are a few air bubbles within the tube, that's also helpful because you can visually see how quickly they move up the tube rather than just relying on pressure of the syringe. You do this prior to placing the tube within the anterior chamber. The other flow check that you can perform is a passive flow check, which you do once the tube is inside the anterior chamber. You put a drop of undiluted fluorescein on the plate and you watch for dilution with egression of the aqueous onto the plate. Once you've checked the flow, you can adjust the flow with any tube ligating sutures around the proximal tube. I normally use 10 sutures and often 2 or 3 of them. Make sure that you don't place these too close to the join between the tube and the plate, because the tube is thicker in this area and it will be more difficult to get a good effect from the sutures. If you have multiple risk factors for hypotony, then you want to consider temporary complete tube ligation with a 6O vicryl, and then also a series of 10O nylon ligating sutures further along the tube over where you have the intraluminal tube suture. So let's talk about post-operative management. In the initial post-operative period, if hypotony occurs, you need to act decisively in a stepwise fashion, depending on how the eye is responding to the hypotony. The first line of treatment is using atropine drops, and the reason for this is that they relax the muscle, the ciliary muscle, and it allows the ciliary body to remain against the inside of the wall of the eye. This enables the ciliary body to continue producing aqueous without restriction. If the ciliary body develops an effusion, then it reduces its production and you get a vicious cycle of hypotony ensuing. If the eye is more problematic and the anterior chamber is shallowing significantly and you start to have touch with the cornea, then you want to reinflate the eye, either using cohesive viscoelastic or gas such as SF6. Then if this is not working after a period of time, you need to look at adjusting the flow through the tube, either using intracameral tube ligating sutures or subconjunctival tube ligating sutures or reinsertion of the luminal suture. You also may consider draining choroidal effusions if they are touching. Usually the intraocular pressure gradually elevates over the first 4 to 6 weeks as the plate encapsulates. This is a clinical photograph of a patient who has retinal folds and mild disc swelling from hypotony. This is more common in the late postoperative period in my experience. Once the initial hypotony has settled and you've dealt with any choroidal effusion, or the choroidal effusions have resolved themselves with your treatment, then this is the biggest threat to the vision in the late postoperative period. So if the hypotony persists for longer than 6 to 8 weeks and the vision is reduced, then a procedure to reduce the flow is recommended. Occasionally, patients can have hypotony, but if they don't have any visual reducing conditions, then it's not necessary to go in and perform further procedures unless the vision is being affected. And I've got a few patients who are continuing with pressures of 2 or 3 several years after surgery who haven't had any problems from that and have normal vision. So treat the eye and treat the vision. Intracameral tube ligating sutures are an option. My preference is subconjunctival tube ligating sutures because it's possible to laser them as long as you place them beyond where the patch is covering the tube. The other options are removing the tube from the anterior chamber, either at the limbus or from under the patch graft, and then applying tube ligating sutures before replacing it into the anterior chamber. The bonus about this technique is that it allows for an active flow check so that you can definitively assess your tube ligating sutures before you put the tube back into the eye, rather than making a best guess in terms of how tight those sutures are. The other procedure, of course, is removing the tube from the anterior chamber and tucking it back and up under the conjunctiva for the time being and suturing the track into the anterior chamber to make sure that that doesn't leak. This allows you to put the tube back into the eye at a later date once further healing around the plate has been allowed to occur. The other time that late postoperative tube hypotony can occur is if you've recently removed the intraluminal suture. I will often wait 6 months to remove my intraluminal suture. However, it's still possible to develop hypotony related to this action, and sometimes the intraluminal suture needs to be replaced. It is possible actually to remove the intraluminal suture partially, and if the patient has risk factors for developing hypotony, then I may remove it partially so that the suture is still within the tube but not beyond it and onto the plate. And this can be helpful, removing it in a couple of stepwise fashions. However, if you've removed it completely and you've got hypotony, then you may want to replace it, replace the intraluminal suture either ab interno or ab externo. If you're performing this ab interno, you need to hold the tube so that if you reach a resistance, if you have some resistance, then you can still feed it up inside the tube. If you're placing it ab externo, you need to offset the incision into the layers so that you carefully avoid exposure of the plate in the post-operative period. So in summary, post-operative tube hypotony is best avoided, so make sure that you plan your surgery carefully. Use tidy surgical techniques to minimize the risk of hypotony and act decisively if the hypotony is causing choroidal effusions that touch or vision loss. Thank you very much for your attention.
Speakers and moderators of this session, you are live.
Thank you, everybody. It was a great session about hypotony. I enjoyed too much and learned too much. Now we have some time to questions. Professor Antonio and I will can make and read the question of the attendants. I have first questions for all of you. You mentioned it, but it's necessary to say it. Some people think that old IOP below 6, it's called hypotony, but if we don't have some corneal damage or macular damage, we have to wait. How much time we have to wait if we don't have symptoms? We only have hypotony, IOP below 6. It's necessary to manage this kind of cases. Maybe Vicente can answer it.
I think if just only the low IP and there's nothing changed, I believe that we can just leave it right there, whatever, as long as possible. I mean, as long as it can be, because if there is no other, visual loss, other structural change or other functional change, it means that, that IOP can be enough for that eye. I think we don't need to do anything much. Okay, just wait and see. Yes, that's it. I'm not sure about the others. Maybe you have some kind of the different opinion on that.
I fully agree. I think I have quite a few patients with the pressure between 2 and 4 millimeters of mercury, but there are no other signs of no loss of vision, no corneal edema, no choroidal folds, no optic disc edema, etc. So we just follow these patients very carefully, and I do have quite a few patients that I follow for many years without any need for any surgical approach or any treatment, even medical treatment for that.
Yes, I definitely agree as well. And what interests me is that anecdotally some patients can tolerate a very low number and some can't. And I guess most of us would have noticed that, for example, our normal tension glaucoma patients seem to tolerate an extremely low pressure. And so sometimes I think it's more of a percentage reduction. And so an IOP of 2 or 3 in an NTG patient with no symptoms is a success, not a failure.
I strongly agree with what you're saying, and I would like to add something. We had some experience with the new 63XN device, and in the early postoperative period, the pressure was very low, and nevertheless, in most of the patients, but none, well, almost none, had any problem. So I think that in some ways, probably also the rate of flow from the anterior chamber to the bleb or to wherever it goes actually plays a major role in keeping the shape of the eye safe and avoid problems. If you don't mind, I would like to ask a question to Shlomo. Actually, it's a question from the audience. So they are very interested about the laser use. And I think this should be an interactive session. So if people ask questions, we should, allow them to have an answer. So everybody is wondering which kind of settings you use for laser when you have a psychodialysis threat.
This is addressed to me, so I'll take the call here.